This webinar has been created by Australian and New Zealander women with Asherman syndrome. Thank you to the Women's Health and Research Institute of Australia and the Australian Women's Health Alliance for their support throughout this project. Please note this webinar has been created with a budget of $0 and very limited technical expertise. Every single person who has participated did so in their own free time. Please be tolerant of any tech issues. We have all done our very best. Hi, my name's Cynthia and I'll be hosting today's webinar. I have a condition called Asherman syndrome, which is characterized by the formation of significant scarring in my uterus. And it's actually caused by an extremely common procedure called a dilation and curettage. As a result of this procedure, I have become infertile. The chances of carrying a child have been taken away from me. And the difficult part is that it's actually preventable. And that's why we're here today. I want to share with you the many stories and experiences of women who have also had adverse outcomes as a result of D&Cs and really raise awareness so that we can prevent the significant trauma from occurring as a result of D&Cs. You'll be hearing my voice as we walk through the different stories and hear some important insights from key experts on this topic. Thank you for joining us. Before we go any further, I want to acknowledge that we have speakers and viewers from all over the country. We pay our respects to the traditional owners of the land on which we are all participating in this webinar. We pay our respects to elders past and present and extend that respect to any Aboriginal and Torres Strait Islander people who are joining us today. So as I've mentioned, the topic that we will be exploring is a medical procedure called a dilation and curettage, also known as a D&C. We've pulled together a range of experts who can share their insights into the current situation and what changes must occur. Some of the stories you hear today will be a little heavy at times with mentions of fertility struggles, near-death medical episodes, and mental health struggles. Please seek mental support if you need to and decide if this is the right webinar for you. I also want to acknowledge that the title of this webinar, "It Felt Like I'd Been Sterilized Without My Consent," might be difficult for some people. This was actually a quote directly from a woman with Asherman syndrome, and we think it's important for you to hear the raw impacts of this condition. There's another quote on this slide. We need to have our voices heard so that hopefully one day our pain and suffering has not been in vain. This quote comes from another woman with Asherman's who unfortunately did not have a successful battle with her condition. She was unable to have another pregnancy after developing the condition and didn't have anyone who could act as a surrogate. I'd like to introduce Laura Murphy and Naomi Kate from Asherman's Australia and New Zealand, who we'll be hearing from throughout today's presentation. I personally am a member of this group. It's been a great source of support throughout my Asherman's experience.
Thanks, Cynthia. We are a group of women from Australia, and there's a few women from New Zealand as well. We all have Asherman syndrome, which is a condition that is most often caused by a D&C, and it causes scarring in the uterus. In our group, we have approximately 400 women, and unfortunately every week that number is climbing. The main focus of the group is to hold space for each other and support each other emotionally. We also provide each other with information on treatment and specialists that are available in our areas. And as we're going to explain later, we've recently started an advocacy campaign so we can hopefully reduce the incidence of this condition and spread awareness.
Hi Cynthia, thanks so much for hosting this webinar today, and also just a huge thank you to every single person who's agreed to participate or contributed in some way. It just is so important for us to have this discussion and to work together to achieve change on this issue.
As you can see on this slide, we have a wide range of people who have participated in today's webinar. A few of them have made introductory videos, which you'll see shortly, and the rest you will meet during the course of the webinar series. We have 8 women with Ashermans who have participated. There's myself, Laura and Naomi, Beck T, Beck E, Helen, Leah and Heather. We have 2 gynaecological surgeons who are specialised in Asherman syndromes, Professor Thierry Van Kai in Australia and Mr. Adrian Lower in the UK. We have an obstetrician gynaecologist, Dr. Lauren Kite, who is currently doing a stint in Broome. We have mental health clinicians, psychiatrist Dr. John Lahn, and mental health accredited social worker Martine McDougall. We have an obstetric sonographer and researcher, Sarah Douthwaite. General practitioner, Dr. Jade Wally, who is a GP who has joined us from the Aboriginal Medical Service up in Broome, WA. Our women's health expert is Bonnie Corbin, who is the chair of the Australian Women's Health Alliance. And lastly, we have a surrogacy lawyer, Sarah Jefford.
My name is Thierry Van Kai. I'm a gynecologist and clinical professor at the University of New South Wales. I have had interest in Asherman syndrome since 1982 and treated quite a few patients.
Thank you. I acknowledge that I'm joining this webinar from Wurundjeri country. My respects to elders past and present. I'm the chair of the Australian Women's Health Alliance. The Alliance is made up of individuals and organisations across Australia who are passionate about gendered approach to healthcare. We provide independent, evidence-based advice to draw attention to the issues, often cross-cutting, that impact women's health. Women experience gender discrimination in healthcare, which can result in delayed access to care, misdiagnosis, and neglect. At the Alliance, we look beyond the medical model of health to recognise the social model of health. So yes, health is about a compassionate health system. In order to prevent patent disease, we also need things like access to income, safe housing, friends, and connection to our communities.
Hi, I'm Adrian Lower. I'm a consultant gynecologist in London, and I have a very strong interest in Asherman's syndrome. I've been invited to join this webinar today to give my view on Asherman's syndrome, the way it's treated in the UK, and to talk to you about some of the medical legal aspects of it, particularly with respect to consent. It's lovely to join you today. I have a great affinity to Australia. I spent a very happy year in Perth from 1989 to 1990 working at the Pivot Medical Centre, which I'm sure some of you will know. So I'm very pleased to be speaking to you in Australia, although it's quite tricky doing it in isolation here and just talking to my iPhone. But I hope that you find what I've got to say interesting.
I'm Dr. Lauren Kite. I'm an obstetrician and gynaecologist and specialist pain medicine physician, and I currently live and work in Broome in far north Western Australia.
Hello, my name is Dr. Jade Wally. I'm a GP currently working in Broome. I have a diploma in obstetrics as well, and I'm currently in between a couple of areas in that I'm working as a GP in couple of remote communities up the peninsula of Broome, about 2 hours away by car. And I also work at the Aboriginal Medical Service in Broome, as it's a 4 weeks roster, 4 weeks on roster up the peninsula, and then 4 weeks in Broome. In that 4 weeks off, I do a couple of days at Brahms and then a couple of days at the hospital in obstetric care.
Before we go any further, it's important that we're clear on what a D&C is. This picture here is a still shot from a recent ABC News story, which explained it in a way that made sense to most people. A D&C is an operation that may be performed on a woman to scrape away the uterus lining. The cervix of the uterus is dilated using an instrument called a dilator. The procedure may be used in situations where there's remaining fetal tissue following a miscarriage or abortion, or to remove retained placenta following the birth of a baby. Sometimes a D&C must be carried out as a matter of urgency, for example in the case of severe infection. Other times, conservative treatment options such as medications are appropriate to try first. Risks associated with the D&C procedure may include bleeding, infection, and damage to the uterus. And as we will explore, this can sometimes lead to fertility issues. As we'll also explore, the level of risk a woman experiences when she has the procedure depends on when she is having the procedure and also whether she's had more than one D&C in her lifetime. And here we have a picture, again a still shot from the ABC News story, which shows the scarring that occurs in the uterus when a woman develops Asherman syndrome. Professor Thierry Van Kai, you're Australia's leading gynaecological surgeon when it comes to Asherman syndrome. Women fly from all over Oceania to be treated by you, often after failed treatments in their own jurisdiction. Can you tell us what Asherman syndrome is?
Asherman syndrome is essentially a failure of the uterus to heal properly. That failure is due to the presence of retained products of conception, which then act as a foreign body, or the presence of an infection.
Sometimes you hear people referring to having a certain stage of Asherman's. Can you explain that? Is it a progressive condition that requires urgent treatment?
Staging of Asherman syndrome depends on the extent of the surface of the uterine cavity affected by scarring. Once the scarring is established, in other words, the reaction to the foreign body or the reaction of the body to the infection has settled, that is then stable. There's no extension or no progress of the scar tissue. And once the scar tissue is established, there's also no urgency to remove it. It will in itself not harm. It will cause issues such as infertility, or sometimes pain and change in menstrual pattern, but in itself it is not an emergency that needs to be treated surgically.
Laura and Naomi, can you tell me about the women in your group who have developed Asherman's? Is a D&C usually the cause? Laura and Naomi, can you tell me about the women in your group who have developed Asherman's? Is a D&C usually the cause?
Yeah, so having a D&C has by far been the most common cause for women in our group developing Asherman's, and that's consistent with what the research tells us about Asherman's. There are some other causes that we have seen in women in our group. For example, having an IUD insertion or having a caesarean section. These are much rarer causes of Asherman's, but still equally devastating for the woman because it's the same impacts for them. But just focusing again on the D&C procedure, we did a poll last year on over 100 women in our group who had developed Asherman's as a result of a D&C. We were trying to get an understanding of when that actually had their D&C to see if there was any particular cluster of women that we needed to be more focused on in our negotiations with RANZCOG about reviewing their guidelines. So the first trimester, women that had had a D&C in the first trimester, there was 44 of the just over 100 women. That wasn't surprising to us because you're much more likely to have a miscarriage in that first trimester and therefore need a D&C. There were 10 women who'd had a D&C in the second or third trimester, and then there was 29, so approximately a third, who'd had a D&C for retained placenta and then gone on to develop Asherman's. And again, this is consistent with what the research tells us, that women who, for example, who have a D&C in the 2 to 4 weeks postpartum are actually at significant risk of developing this condition, approximately 25% risk. And then we had 33 women who had multiple D&Cs and gone on to develop Asherman's. So again, that didn't surprise us because the research shows that women who have multiple D&Cs are actually at about a 40% risk of developing the condition. So these poll results were significant because during recent media push with RANZCOG, they did commit to reviewing their early pregnancy loss guidelines. And that's great, but we also know that it's really not enough to cover this issue. Because it's not just restricted to that early pregnancy period. We're having women, as you can see, who've had D&Cs at other times or who have that cumulative risk of multiple D&Cs. So only focusing on that early miscarriage period will prevent some women from developing Asherman's, we have no doubt, and we're very supportive of that, but we feel that the review needs to go much further than this.
So we've got a bit of an overview of what a D&C is and how it can lead to Asherman's. I'm keen to hear about the impacts Asherman syndrome can have on a woman.
The paintings on this slide were done by the family member of a woman who has Asherman's. They were donated to us when we were putting together our website. There's just so many impacts that Asherman's can have on a woman and her family. So for one, the impact on her planned family potentially. So some women are never able to have another pregnancy after developing the condition. There's the grief, loss and suffering involved. The impact on relationships. So sometimes it can really impact on partner relationships. Partners can feel helpless or angry or find it really confronting to suddenly have all of these medical interventions or the financial pressures that Asherman's can bring. The impact on extended family as well. So often extended family are caught up in providing support and grieving for the woman as things might not pan out as she'd hoped, or sometimes extended family help with things like covering the cost of surgery or other things that come up as a result of Asherman's. There's the mental health impacts, which we'll leave to a mental health expert to talk about, and the strong sense of violation at not feeling that they were aware of the risk when they had the surgery. Some women also experience ongoing pain as a result of the scarring, even once they've had surgery to treat it. We'll now hear directly from women affected by Asherman syndrome about the impacts that it's had on them. Firstly, there'll be 2 videos, and then Laura is going to read out some quotes.
So following the diagnosis, waiting to see Dr. Kite again, what happened to me was intense anxiety, panic attacks. I can feel myself getting quite overwhelmed talking about it. I needed to take time off work. I needed to see my GP for some medication because I could not sleep and I could not function, which I now know to be PTSD from my birth and the subsequent D&Cs, and also dealing with this new diagnosis, which meant I couldn't have any more children without intervention, and that intervention was not available to me locally.
I had 3 treatments with POFV at different times over 2 years, and I travelled from New Zealand to Sydney, and that was obviously expensive and stressful, and it was very stressful, and but I also wanted to go to an expert, and I knew that POFV took it very seriously, and that's why I wanted to go to Sydney.
My whole life, as I thought it would be, was taken away from me in an instant by a health professional who I trusted, a system that I trusted, but is ultimately flawed. The worst part is that my story is not unique. Altogether, my partner and I have spent $100,000 out of our own pockets on surgeries and treatments associated with Asherman syndrome. I have no children and had always hoped to have 2. At this point, I would consider myself lucky to get the chance to have one. It is not clear if I will be able to have a child at this stage. I am still on the Asherman's journey after 3.5 years and still unable to conceive. It has been life-shattering for my family and myself. I regret daily having that D&C done.
We've got Dr. John Lan, who is a psychiatrist, and Martine McDougall, who is a mental health accredited social worker. Both have supported multiple women with Asherman syndrome. Dr. Lan, have you seen women develop mental health conditions as a result of their Asherman's diagnosis? And do you believe that the lack of informed consent about the risks of the D&C procedure contributes to the distress experienced by women?
Hello, my name's John Lan. I'm a psychiatrist in Perth, Western Australia, and I have many years' experience working in mental health, but in more recent years I've been focused on PTSD and psychological trauma, and I've run a clinic called PAC Centre over the last 6 or 7 years, where that's been the focus of our clinical attention and treatments. I have in recent years seen several patients come for independent psychiatric legal reports who have developed Asherman syndrome as a result of D&C procedures, and so I have a little experience in dealing with and assessing such clinical scenarios. I think the main points I want to make are that Asherman syndrome can result in psychiatric and psychological consequences, which includes PTSD or post-traumatic stress disorder, and also adjustment disorder, which can include significant depression and anxiety symptoms. I'm sure that there are other possible psychological trajectories as well, but these are the main ramifications in my experience from the psychiatric perspective. My feeling is that the key issues are the trauma that's involved in going through such a procedure in certain circumstances, and then particularly the trauma of learning later that the Asherman syndrome has developed, and that the implications of this may be infertility. Depending on the person's particular situation, this may have a variety of psychological impacts. I think it is very important to emphasize that consent is also a key issue here. If there has been valid, informed consent and someone has considered in detail the relative risks involved in a procedure such as a D&C, then I think there's a different psychological result from if such consent is not adequately pursued by the surgeon. And I think that this is a key issue across a number of different surgical processes and surgical procedures. Gaining valid and informed consent can sometimes be something that's overlooked in practice, and can become something of a tick box. John Lyon, Part 2. As well as emphasising the importance of valid and informed consent, I would also emphasise the impact that these kinds of situations can have on trust in the medical profession in general, and this can have an important impact on someone accessing the best healthcare going forward, being able to access the best advice when there's been a loss of trust and a sense of betrayal from a clinician who previously the person had trusted implicitly. So again, the consent issue becomes very important and has long-lasting implications potentially. Thinking about treatment, if someone develops a PTSD, which includes anxiety and depressive symptoms as well as re-experiencing symptoms, those re-experiencing symptoms include nightmares and flashback type memories, as well as symptoms of hypervigilance in PTSD that can include increased startle response, difficulties with sleep, general feeling of being hyper-aroused and on alert. All of these symptoms within the PTSD constellation would normally be treated with trauma-focused psychotherapy, which comes in different forms, and sometimes as well with medicines such as SSRI antidepressant medications, and sometimes other medications to help with sleep and nightmares and to reduce the hypervigilance. So there's usually a multi-pronged approach from the medical and psychological perspective to that treatment. Anxiety and depression similarly will usually have a combination of psychotherapy and sometimes also medications such as antidepressants and anxiolytic medications and medications to assist with sleep. So there's a range of different treatments that have to be brought to bear, and there are other newer treatments which are used as well, and which do not have such a strong evidence base but can be useful for some individuals.
Women commonly report a battle with depression and anxiety and PTSD. They report significant hurt, grief, shock, terror around the realization that I may not get pregnant again, or actually being told you cannot get pregnant again. So grief is really common amongst this cohort of women. There's anger at the lack of knowledge to support your informed consent. Women commonly express feeling major depression and dissociation because the reality of their situation is actually unbearable. So struggles in returning to work is common. Loneliness, because people don't understand.
We're going to move on to 3 case studies now, which will open up further areas for discussion. Let's start with a woman called Beck. Her story featured on ABC News November last year. We'll put the link to the article at the end of today's presentation. At her 12-week pregnancy scan, it was found that Beck's baby no longer had a heartbeat. She had 2 D&Cs to remove the retained products of conception. She was not warned about the risk of Asherman syndrome and subsequent fertility issues, despite her 2 D&Cs placing her at a 40% chance of acquiring the condition. 12 months later, after failing to become pregnant again, Beck was actually diagnosed with stage 4 Asherman syndrome, the most severe extent of scarring. Beck underwent multiple surgeries to try and treat the Asherman syndrome. Unfortunately, these surgeries were unsuccessful, and her fertility specialist taking Beck by surprise when he asked her, "Do you have a sister?" as she was unable to carry a baby on her own. Out of desperation, Beck actually flew interstate to Sydney for treatment by Professor Thierry Van Kai. As it turns out, the surgeries Beck had had in her hometown of Perth had made her Asherman's worse. Professor Van Kai was unable to do anything further for Beck and advised that surrogacy would be the only option. Beck and her husband ended up pursuing surrogacy in Ukraine. Professor Van Kai, I'm keen to hear from you. Why did having 2 D&Cs place Beck at such a high risk of developing Asherman syndrome?
The need for a second intervention to empty the uterine cavity does indeed increase the risk significantly. The first intervention could be a D&C for miscarriage, but also a cesarean section or even a normal vaginal delivery. The reason that the second intervention has a greater risk is that it intervenes on an organ that has weakened due to the first intervention. So it is more likely to actually not cope with that second intervention and therefore develop an inadequate healing process.
Syndrome. And can you explain how her surgeries to treat the Ashermans made her condition worse? Do you need a particular skill set to treat Ashermans?
The treatment in this particular patient involved the use of electrical equipment. Electrical equipment in surgery deals with bleeding in the sense that it reduces the vascular supply, which in many cases is an advantage. But in the treatment of Asherman syndrome, it's not. We need the vascular supply to actually promote normal healing. Therefore, if at all possible, we should avoid using electrical equipment to treat Asherman syndrome.
Sarah Jefford, you're a surrogacy lawyer. Beck described her shock at being told she was infertile. Is this consistent with your experience with women who have Ashermans and eventually resort to surrogacy?
Yes, absolutely. Many women who have Ashermans have gone through a long process of treatment for Ashermans and infertility, only to be told that in fact surrogacy is the next option for them. And the biggest shock for them is realising that that simple procedure that they've had perhaps even many years before has now resulted in them not being able to carry a baby in the future.
What does surrogacy involve in terms of costs and impacts?
Surrogacy is altruistic in Australia, so while surrogates can't be paid, the intended parents need to cover her expenses. And that starts right at the beginning with counselling and legal advice, as well as her medication and any IVF expenses. And then during pregnancy, any expenses for the prenatal care, pregnancy massage, maternity clothing. And then, of course, after the birth, the intended parents then need to go through a court process, and that necessarily incurs some expenses as well. What I hear from intended parents is that their budget can be anywhere from $15,000 to $60,000, even for altruistic surrogacy in Australia. And some arrangements blow out even more expensive than that. And that will be dependent on things like the cost of IVF and whether their surrogate has been unwell and needed bed rest and therefore incurred further expenses.
We'll now move on to our second case study. Hayley is a pseudonym. 2.5 weeks after the birth of her first child, Hayley experienced an increase in postnatal bleeding and she felt nauseous. She presented to her local emergency department. A junior doctor advised Hayley to fast in case she required surgery, as it appeared she may have retained placenta from the birth of her baby. However, a consultant doctor advised that surgery, a D&C, would not be required and instead gave Hayley some IV antibiotics and a prescription for oral antibiotics. Hayley went home without requiring hospital admission, but was advised to get in touch with her private obstetrician for any follow-up she may require. Hayley did so and saw the private obstetrician 4 days later, by which time the bleeding had completely stopped and she was feeling well. Nonetheless, the obstetrician decided to book Hayley in for a D&C the very next day when Hayley was 3 weeks postpartum. She did not inform Hayley of the risk of Asherman syndrome or subsequent fertility issues, even though by having the D&C in the 2 to 4 weeks postpartum, Hayley was at a 25% chance of acquiring the condition. During the D&C, Hayley's uterus was damaged and she had persistent bleeding. It was decided to admit her to the maternity ward for monitoring. While on the ward, Hayley's bleeding steadily increased and she then had a life-threatening hemorrhage. She required a resuscitation team, multiple blood transfusions, and had to be rushed back to theatre for an emergency medical procedure to stop the bleeding. In the months that followed, Hayley experienced sharp stabbing pains in her uterus. She was eventually diagnosed with Asherman syndrome, and after local surgery was advised that she would likely require surrogacy. Hayley then flew interstate for surgery by Professor Van Kyle, and after this was able to have a successful but stressful pregnancy due to intrauterine growth restriction. She continues to experience chronic pain to this day as a result of the damage done during her D&C. Now, Hayley actually sought second opinions from other obstetricians in the aftermath of this incident, and I'm going to share what she learned. Firstly, doing a D&C in the 2 to 4 weeks postpartum is associated with high risk of damage to the uterus, including hemorrhage. Hayley was advised that having a D&C at this time had well-known risks, which should have been explained to her. She was advised that her presenting condition had been mild and that because she had responded well to the oral antibiotics from her local emergency department, she hadn't actually needed a D&C. So we'll move on to our final case study. Danny is also a pseudonym. Similar to Hayley, Danny had a D&C 3 weeks after the birth of her first child, after an increase in postpartum bleeding. She was also not warned about the risk of Asherman syndrome or infertility. After the surgery, which had no immediate complications, Danny became concerned when her periods did not return when she stopped breastfeeding her son. Her GP was unconcerned. Danny did some research herself and came across information about Asherman syndrome and joined the Facebook group. She was given the details of Professor Van Kai and sent him a brief summary of her symptoms. Danny subsequently flew herself to Sydney for multiple surgeries. Her Asherman's was difficult to treat and she required IVF treatment. She became pregnant, but there were severe complications. She required an emergency hysterectomy during the birth due to severe blood loss when they tried to remove the placenta during a planned caesarean and was placed in an induced coma. Now I'm keen to hear from the experts. Danny experienced major complications during her post-Asherman's delivery. Do you believe this is related to Asherman's? And do such complications often occur in Asherman's pregnancies? Why?
There's a 5% complication rate in pregnancies subsequent to treatment of Asherman syndrome, which means, of course, that 95% of the time, everything goes well. All these complications are linked to the placenta. The placenta can cause insufficient supply to the fetus, The placenta can grow deeper than it should and therefore cause bleeding at the time of delivery. These are the main issues. The reason for this is that some of the layers within the uterus don't completely heal after treatment of Asherman syndrome, and therefore either do not supply enough vascular nourishment to the placenta or allow the placenta to penetrate deeper into the tissues. But again, 95% of the time, all goes well.